Airway Assessment, a comprehensive guide. Hello, everyone. I'm excited to present Airway Assessment, a comprehensive guide. Whether you work in anesthesia, emergency medicine, or critical care, mastering airway assessment is vital for patient safety and effective care. Today, we'll cover the essentials, from anatomy to management strategies, and equip you with the knowledge to handle even the trickiest airways. Let's dive in. Introduction. Let's start with the basics. Airway assessment is a systematic process where we evaluate a patient's airway to predict how easy or difficult it will be to ventilate or intubate them. This isn't just a routine check. It's a cornerstone of patient safety, especially in high-stakes settings like surgery, emergencies, or the ICU. A good assessment helps us avoid disasters like hypoxia, low oxygen levels, or aspiration, where stomach contents enter the lungs. Today, we'll walk through the airway's anatomy, how to spot a difficult airway, practical assessment techniques, and strategies to manage special cases. We'll wrap up with real-world examples and key takeaways to tie it all together. Ready? Let's move on. Anatomy of the airway. To assess an airway, we first need to know what we're dealing with anatomically. The airway starts at the nose and nasal cavity, our air entry point. But things like nasal trauma can block it. Next, the mouth and oral cavity are our main access for intubation. Limited jaw mobility can make this tough. The pharynx, split into the nasopharynx, oropharynx, and hypopharynx, is a common trouble spot. It can collapse, especially in unconscious patients. The larynx, home to the vocal cords, protects the airway, but swelling here can complicate things. Finally, the trachea is the highway to the lungs. It has to stay open. Understanding these structures is like having a map. It shows us where obstacles might pop up. Take a look at this diagram. It labels these key areas to help you visualize them. Predictors of difficult airway. So, what makes an airway difficult? It's when a trained pro struggles with mask ventilation or intubation. While it's not always predictable, certain signs can tip us off. Look for obesity, a short neck, limited mouth opening. Less than 3 centimeters is a red flag, prominent incisors, or a receding chin. Then there are specific tests. The Mallampati score checks how much of the throat you can see. Class I shows everything. Class 4 just the hard palate. Higher classes mean higher risk. Thyromental distance measures from the thyroid cartilage to the chin. Less than 6 centimeters suggests trouble. And don't forget neck mobility. Limited motion, like in arthritis, ups the challenge. Here's a Mallampati chart and a photo showing how to measure thyromental distance. These predictors aren't foolproof. Studies show only about 25% of anticipated difficulties pan out, but they help us plan ahead. The Lemon Rule. The Lemon Rule is a practical mnemonic designed to help clinicians predict difficult airways by focusing on 5 key factors. Look externally. Evaluate the 3-3-2 rule, Mallampati score, obstruction, and neck mobility. It's particularly valuable in high-stakes environments like emergency departments or pre-hospital settings, where a quick, structured assessment can guide preparation for airway management. Let's break down each component. L. Look externally. Begin by observing the patient's external features. Check for facial trauma, which can distort anatomy and complicate intubation. Large incisors might obstruct the laryngoscope's path, while a beard can interfere with mask ventilation by preventing a tight seal. A large tongue can crowd the mouth, reducing space for airway tools. These visual cues provide an immediate sense of potential challenges. E. Evaluate the 3-3-2 rule. This is a simple bedside test using the patient's own fingers to measure airway proportions. Mouth opening. Can they fit 3 fingers vertically between their incisors? Less than 3 suggests limited access for the laryngoscope. Chin length. Measure from the mentum, chin, to the hyoid bone, should be at least 3 finger breadths. A shorter distance indicates less submandibular space to displace the tongue, making visualization harder. Thyroid to mouth distance, from the hyoid bone to the thyroid cartilage, should be at least 2 finger breadths. A shorter gap suggests a higher, more anterior larynx, which is tougher to align for intubation. If any of these measurements are reduced, it's a warning sign of a difficult airway. M. Mallampati score. Ask the patient to open their mouth and stick out their tongue without phonating, then classify the view of the oropharyngeal structures. Class 1. Soft palate, uvula, fosses, and pillars visible. Class 2. Soft palate, uvula, and fosses visible. Class 3. Soft palate and base of uvula visible. Class 4. Only hard palate visible. Higher scores, 3 or 4, indicate less visibility and a greater likelihood of intubation difficulty. O. Obstruction. Examine the patient for anything that might block the airway, such as tumors, abscesses, edema, or foreign bodies. These conditions can complicate both ventilation and intubation, so early identification is critical. N. Neck mobility. Assess the patient's ability to move their neck. Limited mobility, from conditions like cervical spine injury, arthritis, or prior surgery, makes it harder to position the head and neck for optimal intubation. In trauma cases, assume restricted mobility until cleared. The lemon rule isn't foolproof. No single tool can predict every difficult airway. However, it provides a fast, memorable framework to identify potential challenges early. It's most effective when combined with other assessments like patient history or additional physical exams to form a complete airway strategy. In practice, Lemon helps you anticipate difficulties and prepare accordingly, whether that means selecting a video laryngoscope, adjusting your technique, or having a backup plan like a surgical airway ready. Key takeaway: the Lemon Rule is a quick, structured tool to flag airway difficulties. It's about preparation, not perfection. The Cormack-Lehane grading system. The Cormack-Lehane grading system is a standardized method used to describe the view of the glottis during direct laryngoscopy. It's an essential tool for anesthesiologists, emergency physicians, and anyone managing airways because it helps predict how difficult an endotracheal intubation might be and informs the choice of techniques or equipment. Here's a breakdown of how it works. Grade 1. This is the best-case scenario. You get a full, clear view of the glottis, including the vocal cords. Intubation here is typically straightforward, and you can usually proceed with standard direct laryngoscopy without complications. Grade 2. You see only part of the glottis, often just the posterior portion or the arytenoid cartilages. While not as ideal as Grade 1, this view still allows for manageable intubation. You might need minor adjustments, like repositioning the laryngoscope or using a bougie to guide the tube into place. Grade 3. Here, only the epiglottis is visible, and the glottis is completely obscured. This signals a more challenging intubation. You may need to rely on advanced tools like a video laryngoscope, a bougie, or even fiber optic assistance to get the tube in successfully. Grade 4. This is the toughest situation. Neither the glottis nor the epiglottis is visible, just the soft palate or tongue base. Intubation becomes very difficult, often requiring alternative methods like fiber optic intubation or, in extreme cases, a surgical airway. Why does this matter? The Cormack-Lehane grade gives you a quick way to assess and communicate the intubation challenge ahead. For grades 1 and 2, you can proceed with confidence using routine techniques. For grades 3 and 4, you'll need to be proactive, having backup plans and specialized equipment ready before you start. A little context. Pre-procedure assessments like the Mallampati score or the Lemon Rule can hint at what grade you might encounter, but the actual grade is determined during laryngoscopy. That's why it's critical to stay flexible. Sometimes the view is worse than predicted. Clinical relevance. Knowing the grade helps you tailor your approach. For example, A grade 3 or 4 might prompt you to call for a video laryngoscope early or prepare for a rescue technique. It's all about being prepared and keeping the patient safe. Assessment techniques. Now, how do we assess the airway? It's a three-pronged approach. First, the physical exam. Inspect the face, neck, and mouth for things like a beard, large tongue, or neck masses. Palpate landmarks like the cricoid cartilage to get a feel for the anatomy. Second, patient history is gold. Ask about past intubations, surgeries, or conditions like rheumatoid arthritis that might stiffen the neck. A patient who says, "Last time they struggled," is giving you a huge clue. Third, we can use tools. Standard laryngoscopes, video laryngoscopes for better views, or fiber optic scopes for tricky cases. The trick is to weave all this together into a full airway profile. In emergencies, time's tight, but even a quick check can make a difference. Special considerations. Not all airways are the same. Some patients need extra care. In kids, the tongue's proportionally bigger and the larynx sits higher, around C3, C4, not C5, C6 like in adults. So intubation angles differ. For trauma patients, think cervical spine injury. We keep the neck still and watch for blood or debris clogging things up. Other cases? Pregnant patients might have airway edema from fluid shifts. Obese folks have excess soft tissue, and tumors can distort everything. The point is, one size doesn't fit all. You've got to adapt your plan, maybe use a smaller tube for a child, or stabilize the neck in trauma. Flexibility is key. Management strategies. Once we've assessed the airway, we tailor our management. The assessment tells us what gear to grab, like smaller tubes for a narrow airway, and which technique to use. Direct laryngoscopy is the classic go-to, but if the view's bad, video laryngoscopy can save the day. For awake patients with tough airways, fiber optic intubation lets us thread the tube carefully. If intubation's off the table, supraglottic devices like an LMA can bridge the gap. Worst case, a surgical airway like cricothyroidotomy. Here's the golden rule. Always have a plan B. Studies show 93% of difficult airways are surprises, so prep for the unexpected every time. Case 1. Obesity and anatomical challenges. Let's bring this to life with 3 cases that show how airway assessment turns potential chaos into controlled success in adults. Picture a 45-year-old man who's obese with sleep apnea, a walking airway challenge. His pre-assessment flags a Mallampati class 4, short thyromental distance, and a thick neck. Sure enough, direct laryngoscopy gives a terrible glottic view. But the team's ready. They'd seen this coming and switched to a video laryngoscope, nailing the intubation. This one's all about spotting the signs early and having the right tools lined up. Case 2. Medical condition with limited mobility. Next up, a 60-year-old woman with rheumatoid arthritis and a cervical spine fusion, now in respiratory distress from pneumonia. Her neck won't budge, and her mouth barely opens, troubles written all over it. The assessment highlights these risks, so the team opts for an awake fiber optic intubation. They glide past the challenges without touching her neck, and she's intubated safely. This case shows how knowing the patient's history lets you tailor the plan perfectly. Case 3. Trauma with facial injuries. Last, a 30-year-old guy crashes his car and rolls into the ED with a broken jaw and swelling everywhere. He's agitated, his airways fading fast, and time's ticking. The team quickly clocks the facial trauma and swelling as red flags. They go for a rapid sequence induction, using a bougie and a smaller tube to tackle the messed-up anatomy, and get it on the first try. This one proves that even in a crunch, a sharp assessment keeps you ahead of the game. These aren't just stories. They're real proof that airway assessment is your lifeline. Spotting trouble early means you can pick the right move, whether it's a video scope, an awake approach, or quick thinking in an emergency. It's all about turning "oh no" into "we've got this." Conclusion. Let's wrap up. Airway assessment isn't optional. It's the bedrock of safe care in anesthesia, emergencies, and beyond. Knowing the anatomy and spotting predictors like a short neck or high Mallampati score lets us prepare smartly. Tailoring our approach, whether it's picking video laryngoscopy or prepping a surgical kit, boosts our success rate. My challenge to you: practice these skills regularly to get comfortable and keep up with guidelines like the ASA's difficult airway algorithm. It's all about being ready for anything. Thanks for listening. References. If you want to dig deeper, here are my sources. The Life in the Fast Lane article on airway assessment is our main guide, packed with practical info. The ASA difficult airway algorithm is a gold standard for managing tough cases. And for a deeper dive, check out Miller's Anesthesia or the Emergency Medicine Manual. Thanks again, and I'm happy to chat about any of this.